There we go. And I'm going to pass the baton actually to Judy to say hi and kick us off.
Excellent. So welcome everyone. And we are going to start with a roll call. So I'll go in order that is on the screen. So Crystal.
Here, thanks.
And Sharon Brown. It's alphabetical by the last name. Tony.
I'm here.
Michelle.
Good afternoon.
Nancy, I saw you pop on.
Hi.
Tracy. David.
Hello.
DC.
Hi, DC here, thanks.
Sharon Eloranta.
I'm here. Hi.
Greg.
Yeah, hi. Good afternoon.
Chandra.
Hi, I'm here.
Meg. Cheryl. Lon.
Hello, I'm here.
Kevin. Eileen. Katina.
I'm here.
Mandy.
I'm here.
Jonathan.
Here.
Sarah.
Hi, it's Sarah Stokes from Kaiser Permanente.
Linda.
Hi, thank you.
Sean. Stacy. Ginny.
Hi, Judy.
Hello. Ooh, it's a godchild. It's so fun.
I have a 4.5-year-old here, home from daycare with an earache.
So fun times. And Maddie.
I'm here. Thank you.
Great. Thank you all. So this is our 4th committee meeting, and we are really going to get into it, I think, today. So that will be fun. We're going to start, and I suspect not, well, actually, I know not finish today, but start our discussion of claims-based measurement with a focus on provider and facility codes. And I appreciate all of you that gave us some feedback. We'll use that to try and get to decisions a little quicker. I think we'll get started after Jean Marie leads us through an approval of the November minutes.
All right, thanks so much, Judy. Appreciate it. May I have a motion to approve the November minutes, please?
Motion to approve.
Any second?
Second. DC.
Second.
Thank you. Any discussion? Okay, vote to approve. All in favor say aye.
Aye.
Hi.
Aye.
Aye.
Any nay? Minutes are approved. Thank you very much. And I know it's at the beginning of the meeting, but we're actually going to put the public comment forward right now, just to give folks an opportunity. And then that way we can go straight into our discussion afterwards. So Judy, you want to make the call?
Sure, although we're a little early, I think.
We are a tad early, yeah.
I don't know if there is anyone from the public on our meeting.
Not that I am seeing. It's looking like all committee folks.
Yep, committee folks and staff folks. Yep. So that is all good. Maybe I will pause in the presentation at 2:15 to see if anyone has joined, and then they can talk then. And just to make sure that we get there. So we decided to put it at the beginning this time, so that we could make sure that we don't run out of time for public comment, but I guess we'll see.
Yeah, we can come back to it. That's fine. So
Yes. So, so I'm going to start with a sort of refresher and talking about the ground rules. So as a reminder, we are sort of thinking about this Venn diagram of primary care claims in terms of overlapping circles of the who, the where, and the what. And that little overlapping bit is going to be primary care spend. We have talked a little bit, and I know some of you have provided feedback that these are going to be our working definitions that once adopted will be updated relatively infrequently. I think once the committee is done with its work, we can talk about how often we want to change the definitions. But most other states that have been doing this think that they shouldn't be changed very often, maybe every 5 or 10 years, so that there can be some consistency of measurement across things. I also want to remind folks that we aren't changing statutory definitions that are already in place. An example of that is the naturopath physician being in the narrow category because that is in statute. I also wanted to take a moment to talk about how this measurement work is separate from, but related to the work that HCA has been leading on the primary care transformation model. And I think this is a really important point because in talking with some folks, it sounds like there's been some conflating or confusion about how these are either the same thing or being launched at the same time. And they're definitely similar, but they are separate efforts that hopefully will kind of reinforce each other. So this, this primary care claims-based work is, actually there's a slide on this later, so maybe I don't need to talk about it too much now, but is separate from the building of what advanced primary care looks like and how that is financed. This will measure the amount of financing, and the other talks about how the financing and structure of primary care happens. So, and then finally, one thing is we've been going over these codes internally and looking at what other states have done and looking at the presentation we had last time by Josh Lau and his group. It may be that for some pieces that we can't get to agreement, we may want to set a threshold. So say if there are less than 50 claims, we'll kick it out of the definition. But if there are more, then it stays in the definition or something like that. Definitely with the work that Josh's group did, they found that in some of those overlapping Venn diagrams, there were no claims or very few claims that fit that. And I think we are really trying to get at the bulk of claims. And so I just want you all to tuck that behind your ear to think about later, because there may be some things, if we can't get to agreement, we might want to use a data threshold the first time the data is run to get an idea of that. So are there any questions about this? Okay, so I'm going to go through a number of slides to sort of set this up, and then we're going to go back over the slides and we're going to have a discussion. So, so hold your thoughts until we get all the way through, and then we'll dig in. So this is the list of primary care providers for the narrow definition. And then this is the list of primary care providers for the broad definition. And so we will spend some time, I'm 100% sure, talking about what stays in and what stays out of these lists. We also have a separate spot for physician assistants and nurse practitioners because they have slightly different coding. And we will talk about that later. And then facilities, so those 3 slides are kind of the bulk of the provider, the who part of the definition. And then the second part of the meeting will really dig into the facilities, or the what part, or no, not the what, the where. What comes after this, either the next meeting or the meeting after that. So this is the where. And then the next slide. I wanted to remind folks of the statutory language that created this committee, because I think there is a little bit of confusion about where behavioral health fits into this. And I think that'll be something we want to discuss. So it does say that part of what we want to do as a state is to support advanced integrated primary care involving a multidisciplinary team of health and social service professionals. And you can see that increasing the primary care and behavioral health workforce is part of what they want to do. And then a later section says, in developing the measures and reporting, the board shall consult with primary care providers and organizations representing primary care providers to review existing work, including but not limited to, and then there are a number of things there, but one of them is the work of advancing integrated mental health centers. And so I do think we're going to have to wrestle a little bit today about how we measure integrated behavioral health versus separate or standalone behavioral health. So, so another piece to think about. And then we had, I don't remember, we have 2 or 3 slides of feedback, but this is sort of, we're gonna toggle a bit back and forth and go through each of these groups kind of individually. We have 2 slides for feedback. The questions we're going to do later. So for the narrow providers list, there has been feedback from different folks to add internal medicine peds, to add OBGYN, to add a nurse, to add a homeopath, and to add advanced practice midwife and midwife. And then for the broad providers list, people thought we should remove providers who are not accountable. The majority of providers are behavioral health and shouldn't be included in primary care analysis. Here's another behavioral health providers or specialty, not primary care. Adding perinatal health and associated providers, removing homeopath, and then wondering about advanced practice midwife versus a certified midwife. And then on the next slide, because we pulled them out separately, the NPs and PAs, either to remove altogether the psychiatric and mental health ones, or to add them to the broad list, or add all categories to narrow. If the nurse practitioner acute care is hospital care, then remove it. That will get flagged when we decide the where part of this. And then for NP, PA, and PA medical, only include if a provider practiced in a primary care facility. So again, we're starting to see some of these intersections where each of the pieces, I think, as we make decisions, will help define what overlap is in the center that we're going to get at. And then for facilities, wondering about critical access hospitals providing primary care, whether primary care clinics are part of outpatient hospital departments, and what does that look like? What about urgent care clinics, and what about virtual care? So, so these are the things we're going to go over, and I'm hoping we'll have a robust discussion. But I'm going to pause again before we get into it to see if there is any public comment. And I don't know, I'm scanning the list to see if there's anyone who is, there's a couple of outside people now, if there's anyone that wants to make a comment or not. Okay, So let's dive in. So Jean Marie, I'm going to have you flip back to that first narrow providers list. And I think you guys have the slides. So if you want to pull them up separately, that is one way to do it. So this is our list of narrow definition primary care providers. And the first suggestion is to add internal medicine peds double boarded. Do people have, and I think how we're going to do this is sort of go over each comment or perhaps cluster of comments. So the next one, I'm going to have like a cluster comment. But let's have some discussion about pro and con, either adding or removing, and then have someone make a motion about that. So internal medicine peds, Mandy?
I guess I'm not familiar with the differentiation. So would we consider an internal medicine pediatrician? Would you go to that doctor for primary care services?
I think you could.
Absolutely.
Yeah.
Yeah, Minnie, this is, oh, I'm sorry, Judy.
Oh, go ahead, Cheryl.
I actually am the one who put this on the list. So you can probably tell. So I trained in the Midwest, and internal medicine pediatrics was actually quite common. So all the training programs had, and this is an option, and they are primarily primary care providers. So they just, if you just combine internal medicine and pediatrics, that they do 2 years of internal medicine, 2 years of pediatrics. They are double boarded, and most of them provide primary care. There aren't tons of them in the state of Washington, but I know in the University of Washington system, we have a couple. And I don't know, Judy, if you have any insight into that. I think this is a small group for us in Washington, but I personally would absolutely put them in primary care.
Yeah, I guess I would agree too, because that sounds like they are primary care.
It's kind of like family medicine, except no delivering babies, and it's a longer residency, but they do both.
Can I ask a weird question? Is there a whole separate sort of taxonomy code separate because they're both internists and pediatricians, which we're including? I mean, and I
Yes.
agree they're primary care providers. What about then med psych? I mean, that's a residency too, and you get boarded in internal medicine and psychiatry. I think probably they're doing all primary care too, right? And is there a separate taxonomy code for them? And is that relevant for these purposes?
That's a good question. I don't know that there is, but there could be. Jean Marie, can you mark that for us to go back and look at
To check,
internal
yep.
med psych? Yeah. So it sounds like there's a general agreement to include. Does anyone want to make a motion?
Motion to include.
Second.
And all in favor?
Aye.
Aye.
Any opposed? Great. So the next one I think is going to be a little harder. That was a good warm up. So the question about whether to add OBGYN, and I'm going to flip into that advanced practice midwives and midwives. So a few different people made some of this comment. And so wanna hear what people have to say.
Well, this is Sharon E. And I suggested adding OBGYN, not because I think that's necessarily the best match for primary care, but many women of childbearing age do have an OBGYN, and many of them have that doctor only and not another one. I mean, at least that's an impression that I have that may be garbage. So I'm happy to hear from others and saying that may be their source that they go to, say, I haven't had my flu shot yet or whatever. So maybe that makes sense for me. And maybe again, this is my misunderstanding, the constraints of what we're in, but I would say if we add OBGYN, then I would guess advanced practice midwife, if that means they are ARNP, because that means they're a person that is licensed and it's within their scope to diagnose people. I really don't think that this primary care thing should be broadened to those that do not diagnose and treat. That is my opinion. That's where I stand on those guys.
Great. Ginny?
Hi, this is Ginny. I agree with Sharon. I'll speak for the female millennial cohort to the best of my ability. A lot of colleagues, right, do see an OBGYN as their primary person. And to me, the stepping back and the thinking about the intention of this group is really important here, especially, right, if it is to improve our population's health. That's a big proportion of sort of an opportunity to improve health of those people. So I would argue for including it.
So to amplify Ginny's,
Yes, Cheryl.
So I agree that and I want to go back to the intention of the group to improve population health. I mean, one of the things that for me is getting a little bit lost is relationship. If you have a relationship with a provider who provides you primary care, in a sense, it doesn't matter who that provider is. There's certain skill sets that can do it. But I mean, family medicine, we always think of them as primary care, but I'm sure that there are family practice people working at sort of doc in the box places that would be providing the care that's not primary care. So in a way, all of these specialties can provide primary care, but they don't always. So I don't know if that helps or not.
Yeah, I do think it's a good point. Where we're trying to get to is that overlap. So it's the provider and the service and the place that will make this primary care or not. So yes, Mandy?
Actually, Cheryl's had her hand raised, so I'd like to hear from her first.
Oh, sorry.
Well, thanks. Well, I'm going to say, okay, I do not believe that OBGYN or advanced practice midwife and midwives are primary care providers. I do believe they provide some primary care services, absolutely. And I understand that for some people, this is the only provider they see, but that doesn't necessarily mean that that person's acting in the role as a primary care provider, especially if we look at our definition that we agreed on of primary care. That's not what OBGYN is. That's not what a midwife is. They provide some primary care services. And so Judy, I'm trying to rectify what you just said with how my belief on this is, does that mean that based on what I just said, would I say you include them or not? Because I don't believe they're primary care providers, but I do believe some of the services they provide are primary care. So I don't know if that means they're in or out.
Yes.
Maybe you could clarify that for me.
Well, I think we should talk about it because yes, it could be either way. So Mandy?
Yeah, I think this comes into, especially in the age group, for a lot of women, this is going to be their only contact with the healthcare system. It is going to be continuous if they go early enough. And then I'm just thinking of like some of the efforts in Medicaid to expanding postnatal care and postnatal coverage. And so you would be continuing, I'm assuming that you would continue going to your OB for those services, but it's the OB providers aren't necessarily just providing the services related to your pregnancy. They also have to manage some of your other health conditions as well. So, for me, I think if we look at the broader umbrella of women's health, including women's health providers as primary care, I think that will help, I think just with the whole group and trying to increase primary care services. And if we do this the way we did previously, where it's both the provider and the service, then you wouldn't count some of the services that they do as under that primary care umbrella, but you would count the ones that do fall under, and that's why they were in the broad definition. on the OFM report.
Great, David?
Thanks, Judy. I think at the earlier meetings, you brought up the point that there are other states that were benchmarking to that had calculated the 4% of spending and 12% of spending. So I'm wondering if you happen to know if specialties like OB-GYN were included in those exercises, and is it important for us to consider that if we're going to try to benchmark to these other figures?
Oh, that's a good question. And I know that they're included in some states and not included in others, and I don't know what the bulk of that is. Jean Marie, do you know?
As I struggle to get off mute. I have a document with compared, I don't know off the top of my head. I think I want to say that there are a couple of states who do move OB into what we would call the narrow bucket. I don't think I'm pulling that out of thin air, but I would need to go back and check, and I can definitely pull that up with the research that I have. So.
Okay, thanks.
Yes, and I will say that, you know, we can include them on the narrow or the broad provider list. And this particular discussion is whether to include them on the narrow list, because I think they're already on the broad.
That's right, they are already on the broad. So really, it's several of these categories, it's talking about moving them from the broad to the narrow. So like the homeopath is already on the broad. Actually, all of these, but everything except internal medicine peds is on the broad list already.
Yes, so Tony?
Thanks, Judy. I actually was looking more for clarification between the narrow and broad list. You know, on the narrow, you're looking for really those providers trained and exclusively, or at least to the degree that you can, providing primary care with first point of contact and truly comprehensive primary care, and then on broad, we're kind of on the broad, rather, we're trying to expand that definition to pick up those who are providing those services, as Cheryl was saying, but aren't necessarily primarily primary care providers. I wonder if you could speak just a little bit to that distinction between the narrow and broad category as we think through this.
Yeah, that's a great question. And it's probably something to discuss amongst ourselves to figure out, because we might each have a different definition. But in general, I would say, and not every state does it this way with a narrow and a broad list, but I think those that do, what they're trying to get at is that narrow is like definitely primary care and sort of the bulk of things, and then the broad is meant to capture things that are also primary care but may not always be primary care, or maybe a little out there. Not out there in a bad way, but you know, not 100% primary care all the time. And then that's where the sort of the concentric circles get helped with that. So I'd love to hear other people's thoughts about that too, because I think that that's a piece of what, especially with these last four, that we'll get into the next two after this part, but whether to bring them into the narrow provider or to leave them in the broad will help us define what we think about that. So Sarah?
Yeah, I was just reflecting on and looking at the definition from the Washington Health Alliance on how they look at primary care. And within, so just in support of adding those providers to the narrow list, they do add, when we're looking at attribution, we're looking to see, you know, do these patients have specific E&M visits? And then is the practitioner specialty within a subset of specialties that the WHA has come up with? And so we definitely do assign patients to OB-GYN as almost as if they are the primary PCP. We also add homeopathy to our definition, internal medicine, pediatrics. So I just wanted to add that as well, because that's kind of another, I think, downstream thing that occurs when you start to add these providers more to the narrow list is how does that affect attribution and assignment?
Great. Chandra?
Yeah, I think I just had a question about, I thought we were working towards one list. So is there a reason why we're trying to determine if a provider should be on the narrow or broad?
That's an interesting question. We had it narrow and broad before, and I think that's what some other states do. And so we could decide if we want to make just one list. We could definitely do that. And take out the narrow and broad and just use the intersection parts of type of provider, type of service, place of service to get us there.
And I thought that like part of our discussion around the definition piece was to kind of just firm up the definition so that we could decide, you know, which providers and services are consistent with that. If we are working towards two different sets of measurements, narrow and broad, I'd be curious how that interplays with the 12% target. And if we're, I guess, you know, it seems like two measurements that we're making rather than the one.
Yeah, I guess one thing I'll say to that in my mind, the two different definitions provide a range for which the true percent is, you know, somewhere in between, because none of this will be perfectly exact, even if we do include non-claims based. It turns out this is just extraordinarily hard to do. So the range sort of gives some sense of that. If there's narrow and broad. That being said, it is not clear which one the 12% refers to, or sort of how that is. And there isn't a date, which is something that also, excuse me, I've heard rumors about of there's not a date that we get to 12%. I've heard some rumors we have to get to 12% by next year, but we are barely going to know where we are by the end of this year, let alone get to 12%. So we've got some time to think about that. And I think I'd reflect that question back to you guys about what you think. Sharon?
Yeah, hi, this is Sharon, and I agree with Chandra. That's basically what I was trying to say, because I was a little confused about why there were two lists, and a little bit concerned that, you know, we might try and say, well, hey, look, we broadened the playing field, so there's so many different types of providers that supply primary care. We're already at 12, right? Without doing the work that we need to do to say, you know, we know that, you know, in our state, the way our insurance agreements are set up, there's very little incentive to actually attach oneself to a primary care provider of any type and ensure continuity, and all the good things that we all know are what we're trying to get to here. And if, you know, if the fact that we can flip around and make the numbers look better by making the list very broad would be a little unnerving to me. Not that I think we're going to do that, but that was my concern.
Yes, that's good. Nancy?
I think, Sharon, what you just said is really interesting, is can we use this process to incentivize that attachment to a primary doctor? I mean, I just wanted to highlight that and sort of figure out, I mean, I think the purpose of the law, the intention of the law was that we increase continuity. And how can we use this process to incentivize forming continuity in relationships? So I just wanted to sort of add to that, or maybe ask you, Sharon, how you thought we could use this process to get that direction.
I'm not sure I thought that. I thought it in a more kind of, you know, sunbeam and all that stuff, happy running around. Everybody gets all the primary care they need. But You know, working now with Drew, who's our new executive director, and kind of learning more about the lay of the land in Washington state, that we just really don't do a lot of restriction of people's choices. We don't have narrow networks by and large. People have free range to go wherever they want. And that makes it really hard. I mean, as someone mentioned the Washington Health Alliance, and I'm sitting here sort of cringing because I can't tell you exactly what we use for the definition of primary care, and I'd have to ask Mark Pregler, but it is close to, I think, the narrow list. That it's a little, it is a struggle that we go through, and had an internal staff meeting today talking about the patients that we can describe as attributed to a usual source of care versus unattributed, and it's almost half of the people within our database that are quote unattributed. And that is a choice that's being made in our environment by purchasers, health plans, and providers, not necessarily providers. I bet providers would kind of prefer it if they knew who their patient panels were. But people want choice. They want to go where they want, and they don't want to be, told they have to have a primary care. I guess that's what I'm told. Sorry, that got long.
Jean Marie. You had your hand up.
Yeah, I did. I didn't really want to interrupt the flow too much, but I did want to just circle back around and say I pulled up the other states as a reference, and just to highlight for Colorado in specific, I was there. They do include OB in their what they would call their narrower version. Just putting that out there. But the vast majority of other states do not when there are two categories. So I just wanted to add that to the discussion, but I also didn't want to interrupt the flow. So go back and everyone else's thoughts. I think Cheryl, were you next?
Yep, Cheryl's next.
Yeah, I mean, I guess the more the conversation goes on, the more confused I get in what we're trying to accomplish. I mean, are we, when I looked at this and thought about it up front as homework, I pulled up our definition of primary care, right? And use that definition then to say, are you a primary care provider? And so that would mean if OBGYN was narrow in the as listed as a primary care provider, then they're responsible, they're first primary point of contact for all my medical care. They're coordinating the care amongst anybody else that I'm seeing. So if I'm seeing an endocrinologist, a cardiologist, a hematologist, my OBGYN then is coordinating all of that care for me. If it was related to a primary OBGYN diagnosis, maybe they would be, but I would be surprised if an OBGYN was taking on that responsibility. So like, that's why I'm struggling to understand, because if our job is to be looking at spend, I would not put an OBGYN as a primary care a provider by our definition of primary care, but I would say some of the services they provide are primary care. I think that's separate from, are people treating them as primary care providers, and that meaning that's the only doctor they go to. That just because it's the only doctor you go to doesn't mean that that person is providing you primary care. And so that's where I'm struggling. Like, I get it. Some people only go see the cardiologist. Like my in-laws go to their cardiologist a lot, kind of like it's their primary care doc. But if you ask the cardiologist, he's not their primary care doc. And so I think I'm just struggling personally with what are we trying to accomplish here? And if I'm really thinking about spend, I put them in broad. I mean, I don't put them as a primary care provider. I put some of the services they provide as primary care. Like, that's my thought. You guys got to hear my thought process out loud.
That is what this meeting is for. Lon?
Yeah, we had to go through a similar definition in launching the HMO. And so we heard from a lot of OB-GYNs. And so what a lot of them said was, not all OB-GYN consider themselves to be a PCP, even though they provide some primary care services, and mostly because they did not undergo a residency training that's considered comprehensive primary care, like family medicine, peds, or IM. And so, personally, I don't think OB-GYN should be included in the narrow definition due to scope of practice and really not meeting our definition of comprehensive primary care services. And in my personal experience, I've had, many members who are patients who go and see an OB-GYN for their services and consider them a PCP. But many, I would say a lot of the time, the OB-GYN have reached out to me for things that are outside of their scope, like helping manage their asthma, or they get a cold or a URI, and they really didn't know what was the best way to treat them. So that's been my experience. So wanted to give you that perspective.
Great. Nancy?
I'd like to go after people who haven't spoken already, Jonathan and Michelle.
Okay, Jonathan?
I don't have all that much to add because Cheryl's thought process largely mirrored my own, but I just wanted to be another voice of support for the broad definition rather than the narrow. And I guess the three specialties I was trying to think of in thinking through this was sort of like the cardiology example, OBGYN, and pediatrics as an example. Specifically with the frame of mind of comprehensiveness and that being in our definition. I think a cardiologist is often the first point of contact for a large group of people. That's a subpopulation for whom a cardiac need is their primary source for medical care, but they don't necessarily provide comprehensiveness. I think an OBGYN is also often the primary source of contact for a very large subpopulation, that being roughly 50% of our population. And I don't think that should be ignored, but they're not providing the same comprehensiveness as, say, in pediatrics. You're the first source of contact for a subpopulation, but you're the first source of contact for every single medical need. And since you're the first source of contact for every single medical need and then coordinate with other subspecialties, I think that's sort of what differs some of the more narrow definitions of primary care from OBGYN, because you might not offer the comprehensive array of services where you're the first source of contact for every single need, but rather the first source of contact for a subspecialty of services.
Great. Michelle?
I might be doing a little bit of thinking out loud here. But my first thought was to keep them in the broad network, and a lot of my work is based on CMS, MSSP, and I'm very knowledgeable of that attribution process, and that's kind of the way I was thinking of primary care. But thinking about the conversation, and especially with the younger, childbearing age, using OB-GYN as primary care. And I will say I did that as well. When I was pregnant, I had a sinus infection, and I ended up going to my OB for care for the sinus infection. But one thought is possibly to exclude it from the Medicare population, because I would say they're probably not using OB-GYN as a primary care source so much as more of the commercial or Medicaid population. So that's just one thought.
Great. Nancy?
So going back a little bit, and I'm sorry, if it was Sharon who said that nobody has any incentive to stay with a particular practice at the moment, and people seem to want to move around. And, I keep going back to this, I think relationship defines primary care more than anything else, regardless of who or where it is. But I almost think we need to decide whether we want to use the broad list or the narrow list, not who belongs on which. Do we want a narrow group of people, or do we want a broad group, which would include all the narrow with the broad? Or else we're just going to count it two ways all the time. Does that make sense?
Yeah, Nancy, I actually have sorry, I didn't raise my hand, but this is just in response to that. And I'm thinking with Judy, maybe, I know we're going piece by piece, line item by line item, but it seems everyone is circling back to this differentiation between the narrow and the broad, overall. Would it be helpful to do a motion on whether you even want to do those divisions, like have a motion to say, hey, we're doing these, or we're just doing one. Does that make sense to folks? Would that be useful? Judy, what do you think?
Yeah, that might be useful. Do people agree? Tony?
You know, I think I would agree with that, and partly because if we step back, we've been talking about the definition. I think that really does support a lot of this discussion. But the other thing is the intent of the work that we're doing, to the degree that it overlaps with the primary care transformation model, and to the degree that we're actually at some point, hopefully, going to be funneling money to practices to expand their ability to do comprehensive, patient-centered primary care with true screening and treatment of addiction and behavioral health and longitudinal care of chronic illnesses and all the things we're trying to do and have a real hard time doing in primary care. I don't think there can be two lists, right? There kind of needs to be one, and we should set it up so that resources then funnel after we're done with this discussion to those practices and those sites where true comprehensive primary care is the intent of the service they're offering. So I would say one list would be more helpful.
Have a little bit of more conversation on that topic.
Yeah, I have a thought on that, Judy. I appreciate everyone's thoughts, and I don't feel strongly about this, but I actually like the idea of having a narrow and a broad list. I think it allows us to follow a tight definition according to some of the concepts people have brought up, but then it also allows for sensitivity analysis to account for some of the counter arguments other people have made.
Great. Others on this topic? One list, two lists?
Just a quick question. If we went ahead with two lists, would we then count them separately when we're measuring spend? And would we just continually, for the next 5 years, count primary care by this method and by the other method?
So that's what we do now. The current OFM definition has a narrow and a broad list, and so it's reported as a range of spend. And yeah, we would continue to have that range of spend be reported versus a single number.
Judy, I wonder if it might be helpful to talk about behavioral health before we make this decision, because I think a lot of these same issues apply. Some of the points people have made about managing your whole set of services and referrals and so forth, similar to the cardiology argument.
Yes, that is definitely true. Michelle?
I just wanted to chime in that I support two lists. I think the idea of having a narrow to help us benchmark against other states that use a narrow list, but then using an expanded list again gives us that full range. And then as long as they're both trended, I think that would be helpful and consistent with what others are doing.
Okay, Mandy?
I almost feel like it might be easier to think of this if we do the opposite. So instead of sitting here thinking like, so would we consider them primary care? Instead saying, just going with what is just not primary care. And kind of going through each of these and just saying, well, do they not do any primary care to help us really make a differentiation on whether or not we should have them or we should be considering them within the definition or within this list?
So I think if you look at both the narrow and the broad, they're all people that could do some primary care somewhere. That's why they're on the list. We've already excluded the cardiologist, for example. We have already excluded the nephrologist, although I am 100% certain some people on chronic dialysis would include that as their primary care. So yeah, I think maybe let's take a temperature vote to see if we should sort of make a decision on this or not, but by a raise of hands, how many people would support having a narrow and a broad list? And I'm hoping someone can count how many people they are looking at the whole screen. Yes, because I can't quite see that.
So do you, oh, I see a few more hands. I think I saw about 6 folks raising their hands to say, yes, they want both categories. Don't quote me
Actually, I
on
have
that.
9. Yeah.
Oh, you have 9. Okay,
I have
well, there you
9.
go. Don't rely on me.
Do
for that.
other people
Bad
have
eyes.
9? I just did it in a 6x6 thing.
That's
Now
great.
it's back down to 8.
Okay.
Oh,
Well,
yep,
or I'm
9.
just bad at
So
basic.
9, and then how many people favor a single list of providers? Raise your hand. And we have exactly 9. So that isn't going to help us get anywhere. I don't know. I'm trying to think what a good way might be to get us off of this.
Well, can I add, so I voted for a single list, but I could support 2 lists if we're just clear about the purposes for each. So I think somebody brought up that they like 2 lists because the narrow providers could be used for things like primary care transformation. And I agree, maybe we do want to have a list for that purpose. But when we're talking about primary care spend and providers acting in a primary care capacity, maybe we want to use a broad provider list against our 12% target. So as long as we're clear about the uses and limitations of each list, I could support 2 lists.
Okay, that's helpful. Greg?
Oh. Go ahead, Greg.
Sorry, my hand was up from previous.
Oh, from before.
Oh, okay. Judy, I was
but
gonna, nope, go ahead.
I'll just say that I could support 2 lists as well if it was crystal clear on purpose of each.
Okay, great. Linda?
I was thinking, so I completely agree with the idea of what the purpose is behind 2 lists versus 1. I was thinking more along the lines with the 2 lists and with something that Cheryl had said, where when you look at providers, they might be providing, so sometimes their category gets assigned to them. And that had been the case, I know, in the past with OBGYNs being assigned as primary care providers. They much didn't like that. But when we were looking at contracting, they had to be, they were included because that's how they were, insurance companies had visualized them. But if we're looking at the narrow and broad list, if we think about the idea of reflecting that based on a percentage of primary care activity that they do, if we look at doing that, to use that as a threshold for putting someone on the narrow list and then everybody else on the broad, because isn't that what I recall from that last meeting, which was, I had to kind of keep my mind forward with it. And I was thinking at the same time, it was a lot to absorb and it was very interesting and well done, but I didn't have a lot of chance to reflect on it. But what it seemed to be is basically, we're trying to grab data. We're trying to analyze this, and then we're trying to make decisions on that going forward. So, so again, my point is, if we look at a percentage of services provided by a provider to allow them to be included on the narrow list and everybody else is just broad, because we know at some point in time, they probably do provide primary care, but maybe not in that 75% of their life is spent in that world. Just a thought.
Jean Marie?
I was just going to add one thing too to consider is the folks that are not currently present. There are some committee members absent today. You know, it might be helpful to get their feedback as well, but also I know we want to move forward and keep the momentum. So but just wanted to put that out there for folks to think about as well.
So I actually don't like that at all. I think if you're not present, then you
don't get a vote.
Decisions, yes.
Yep.
Because otherwise this process will take even longer. So I think you have to be present to win. Is my thought about that. And it seems like maybe we have a majority that can live with a narrow list and a broad list with adding some language that the narrow list is to be used for primary care transformation investment, but the broad list is more inclusive to include everyone that that might provide some primary care. Is that a fair summary? Is there anyone who cannot live with that? And we can bring back some language at the next meeting about what that looks like.
Yeah, Judy, this is Cheryl. I voted for one list, but I can live with that. Absolutely.
Okay, excellent. And hearing no other naysayers, let's proceed with the narrow and broad. And then I think, I don't know, maybe this is helpful to do this sort of temperature taking again. Maybe I'll have people raise their hands if they think that the women's health practitioners we've been talking about should be on the narrow list. And then next I'll ask who wants to keep them on the broad list. So raise your hand to add OBGYN, advanced practice midwives, midwives to the narrow list.
So you're asking them collectively?
Right. So, yeah. So it looks like there's 2 people. So does everyone else think that they should be on the broad list? If you think those women's health providers should be on the broad list, please raise your hand. Okay, this was easier than I thought. So maybe does someone want to make a motion? Or actually, no one needs to make a motion because they're already on the broad list.
Hey, Judy.
Yes.
Just as a maybe parking lot, you know, what would be super interesting is maybe in some analysis, if OBGYNs were like if more than 50% of what they're doing all day, every day is primary in the primary care service list, or so, you know, that may convince me to put them on the narrow list. You know, just thinking about the other uses of maybe this list. So I wonder if as a parking lot, I mean, that might be an interesting way to think about this too. If the majority of what you're doing all day, every day are primary care services, maybe that does get you on the narrow list.
Okay, I like adding that to the parking lot, and maybe we can do some digging to see if anyone has done that, because it seems like that would be an interesting thing to do. Yeah. So we don't need a motion for that because that is staying as is. So next is whether to add registered nurses to the narrow list. Is there any thoughts and comments about that?
A question, you know, our definition includes team-based care. How often are RNs working in a team where they're the highest level of service?
So there's a number of folks on the call that are in different types of primary care places. I would guess that they are not usually the highest level. There are practices where advanced practice nurses are the highest level, but that's not a registered nurse. Does anyone have anything different to add about that?
This is Michelle. Just from a claims data perspective, there's not many plans that allow RNs to bill on their own. So I'm not even sure how much you're going to be able to identify services that were done by an RN, because usually that's still billed underneath the supervising physician.
Yeah. There are some places, like with the TCM coding, where there's a step of it that has to be accomplished by a quote licensed professional, in which you can see that an RN did the first follow-up phone call or whatever, but the full claim is submitted by the physician or NP or PA.
Okay. It sounds like maybe we have consensus not to add the RN to the narrow providers. They're currently on the broad, so they would stay there, but maybe they don't have a lot of claims to that point. Is everyone comfortable with that decision, or should we change that? Okay, and so, oh, Mandy?
I was just going to say, if there's no way to measure it, then there's no way that we would be able to even track it for, so I think the comments that have been made, I support them, because if we can't measure it, then it really can't be in the definition.
Yes.
Judy, should we consider removing it from the broad list?
That is an interesting question. Maybe let's add that to the broad list category, because I think, yes. And then our last one here is whether to add homeopath or not. And you all note that the opposite of that, to remove homeopath from the broad provider list, will be discussed in the broad section. Does anyone want to make a case for or against adding homeopath to the narrow list?
Right, so this may be my naivete, but homeopath is not just another term for a naturopath, it's a separate provider type.
Yes.
Okay, I would not add them to the narrow list.
There is different training. They are definitely have even, I would say, a different philosophy than the naturopaths. There's some similarities, but there's also some differences.
And they're licensed independent providers?
Yes.
Okay, thank you.
Judy, should they provide care other than homeopathy?
Do they?
Do they? Again, like Cheryl, I'm not completely sure that their scope of practice. I imagined, based on the name, that it's mostly homeopathy.
I think so. And that's an interesting scope of practice question that I don't know. Can my phone a friend staff look up anything about what their scope of practice is?
Does anyone know anything about the, I must admit, I don't know anything about how long their training is, what their training's like. Do they train at Best here, like naturopaths?
I don't think so.
And they can, well, gosh, I should have done more homework. Now I'm feeling like I should have looked this up before, but now I'm just gonna, and they can bill for services to insurance providers? And they're reimbursed? Like, would they even exist in the claims? I guess is really what I'm asking.
Oh, interesting.
Because I don't believe Medicaid pays for their services.
Is there someone here from a commercial insurer?
Yeah, I was just gonna say, if they are a provider that commercial insurance will cover, then they will show up in the claims.
I don't see it listed in the Department of Health as a category. I only see the naturopaths.
Yeah, I was just about to say, when I'm doing a cursory look here, it kind of seems like a square rectangle problem where naturopathy encompasses some homeopathic remedies, but not the other way around. So yeah, I'm not seeing it codified homeopathy.
Are they MDs or DOs, or do they?
No.
I don't think so, no.
I think it's possible for a person to be both, but this is the only thing that I really know about homeopathy is that they're the ones that have the tenet that the less of an active ingredient there is in something, the more powerful it is. So you'll see like concoctions that are like 1 part in 1 million of something or other.
In my quick look at Bastyr, it doesn't look like there's a separate program for homeopaths. So maybe maybe we have our answer to both if there isn't a license to do that. If naturopaths can do homeopathy, then that could get figured out in the services, but it wouldn't be a separate thing. Mandy?
Oh, I'm sorry. I think I left mine up. I was just wondering, does homeopath have their own taxonomy?
They do, at least according to, I think, based on the codes that we pulled from the narrow and broad from OFM, Mandy, they do.
Okay.
And Linda?
Yeah, I was just kind of Googling around.
Yes, that's what I'm trying to do too. Sorry.
And
I'm not very successful at it.
I got to the Washington homeopathy site. It looks to what I quickly breezed through and read is that it's sort of it's recognized but not recognized in the same way, and that people who are homeopaths provide that. They might be a licensed professional, whether it be a naturopath or a nurse or other recognized person in Washington State, but that they also say, oh, I'm a homeopath. And so they work under the other license, but then they have, that's what I'm reading here in this site from WAHA.
This is Sarah from Kaiser Permanente. I just looked into our claim system. I don't see any homeopathy taxonomies in our system.
So maybe does someone want to make a motion about homeopath?
Yeah, I'd be
can
happy to, Judy. I think
cover both the narrow and the broad.
Yeah, I would make a motion to remove them as a provider type from both the narrow and the broad.
Second.
I would agree.
Okay, let's raise your hand if you want. Well, maybe we have, I guess, say aye if you agree.
Aye.
Aye.
Aye. Aye.
And say nay if you disagree with dropping homeopath. Okay. Excellent. So we've made some progress. Jean Marie, can you go back to the narrow providers list? And I don't know if you can edit on the fly, but does anyone want to make a motion about this list, adding internal medicine and internal medicine peds on here as so that would be on here with the rest of this list as the narrow.
I move to add IMPs to the narrow list.
Second.
Okay, everyone who agrees, say aye.
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 And those opposed say nay. Okay, we're making progress. I will say we might add some advanced practice nurses to this list, so we're not totally done with it, but taking it in sections. And I'll also say that we will do some homework to look at internal medicine psych. So we're making some progress. So broad providers list, the first bit of feedback was to remove providers who are not accountable. Can we have some discussion about that? Mandy?
Or what does it, I guess I don't understand the term accountable here. I need a little bit more context.
Yes, so it's in our definition, but that definition is very broad. And so, yeah, I don't know. Does anyone want to talk about that?
I don't really understand the question. What are we talking about? Sorry.
Is to whether we should remove providers from the broad list who aren't accountable, which I think in our definition, we want providers who are, like, that's part of our definition of primary care. I think it's a little bit hard to operationalize accountable. And so maybe that is some of why this is on here. But I want to recognize that someone gave us written feedback about it. And so if people have thoughts about that, then we should talk about that. Mandy?
Yeah, I think in our definition, we may need to have to define some of the terms, because I still don't understand what we mean by accountable. So are we talking about attribution? Or if we're going to have like a master list? I think it's just, I think we might need to discuss what we mean by accountable before we remove providers that we are saying aren't accountable.
Yes, I'll say that accountable is not attribution. Those are two separate things. And yeah, maybe Sharon, do you have a comment on this and your hand is raised?
Yeah, I'm just looking at the list, and I didn't use the word accountable, but I know I was trying to go through and I guess it's more like who ends up being accountable for the care that was given as it was billed, because I guess that's what we're looking for, is for spend, right? And generally that's going to be the licensed PA, ARNP, or physician, DOMD. And that would, unless, you know, we've broadened the scope of services, so it's definitely beyond the medical, like counselor, registered nurse. I mean, I don't know if that's what we mean by the question. So
yeah, Jean Marie.
I just wanted to see, Cheryl, do you have any comments you wanted to make? Because I think this was your feedback that I drew this from. You had mentioned on the broad that you felt that many didn't represent an accountable primary care clinician. So maybe you wanted to speak to your comment.
Yeah, I thought it was me, though it's funny that you can't always remember the feedback you gave, but I'm happy that I was like, I still think that. So I agree with myself. So, I mean, I guess it's just this, okay, a social worker, they're not my primary care provider. They can't provide for my physical health at all, right? It's not in their scope of practice. A psychologist can't provide for my physical health. They can provide for my emotional, behavioral, mental health. So how can any of them be primary care providers? They can't be accountable for all of my health. So I don't understand how a social worker or a psychologist could be a primary care provider. They provide some, what I would consider primary care services, but I don't understand how most of the people on this list could be a primary care provider by our definition of primary care. That's what I mean. So are they accountable for my primary care? And I would say for most of the people on this list, they are not.
Yeah,
agree with
I
you.
think that's a very interesting observation, and maybe maybe we use the word accountable when we talk about the narrow providers, because I think the narrow providers are the ones who are accountable. In my mind, and maybe that's how we help define that. And then the broad provider list includes those who are part of the team that provides primary care.
Yes, I could. I mean, I agree with you, Judy. Many of these, maybe all, I'd have to look real close, could absolutely be a member of our primary care team. And optimally, lots of these people would be on our primary care team. That would be awesome, right? But independently, they could not be like, right? I can hang a shingle as a pediatrician, and I can be a primary care provider. None of these people on this, well, OBGYN, I think, could within their scope of practice. I don't think anybody else on this, well, and these family med, that's yet, and all the family med on here, I assume those are physician. If they are specialized in addiction medicine, but they could still be, that could be a niche, right? But they still can provide primary care. But all of the psychologists, the social work, midwife, registered nurse, they can't hang a shingle and be an independent primary care provider.
Yes, Nancy?
So I feel like this is coming full circle a little bit, and just to go back to our definition of primary care, team-based care led by an accountable primary care clinician. So we have thinking about if these people are part of a team and they're accountable, then yes, that's primary care. But I agree with Cheryl that if the person is not part of a team led by a primary care clinician, presumably the people that are on the narrow list, right? Then that's primary care. But we're coming back to team and accountable and who's leading the team, or yeah. So a social worker could bill as part of a team, and that would be primary care, but there's got to be somebody on the narrow list in that team.
Katina?
Nancy, you stole my words. That's exactly what I was thinking. If they're part of the team-based care, because that's what we're trying to create here and capture all the things that do happen that aren't done by the physician or the PA or the ARNP, who is the accountable primary care provider. Thank you. Stole it.
Great. And Michelle?
Well, I just, again, keep going back to, remember, we're using claims data to try and identify primary care spend. So if they don't match the exact definition of providing physical primary care, such as a social worker, but primary care physicians are being required to add those services and add those team members. And that's the only way you're going to capture it, is by you including those providers. Because a lot of times you can't, I mean, a social worker usually doesn't bill on their own. So, I wouldn't include social workers in that, but, psychologists, they could be part of a team billing on their own. The only way we're going to find that in claims data is by looking for that provider type. So I think that's why it makes sense to include those providers, because we are asking primary care to expand those services beyond, providing the physical medicine.
Well, so today though, and I'm just as questions, I don't know what the right answer is. If my daughter's seeing a psychologist for anxiety, not as part of her primary care practice, right? She got referred to see a psychologist for anxiety. They did CBT together for 15 weeks. Is all of that billed CBT included in the primary care spend?
I agree. It's going to be messy. I mean, that's what's going to be difficult about the way we're measuring it if we're going to use claims. And that's
you have to use claims. How do people handle, like, that's what I'm struggling. I mean, I know this is hard, but how's everybody else handling this? Like, what are they, practically, everybody, there's others, what's everybody doing about that?
And you mean the others? I think other states are using them on the broad list. Like, I think it makes sense to put them on a broad list and just understand that you're probably going to capture some services that are not direct primary care. But, you know, again, you have to have good mental health in order to be able to take care of yourself physically. So maybe it is primary care. I mean, you can really go down the rabbit hole here. So I
Or,
don't-
but, or is it only primary care if it's provided by part of that team? Me just referring you to a psychologist somewhere isn't really coordinated, if, you know, integrated
And I
care.
agree with that. I agree with that. And if we could get to that data easily and have people, you know, when they were credentialed with a insurance company, if the insurance company said, you're part of this team, and you could, you know, try and pull claims data that way, but that's not how it works. So that's why I think it's okay for them to be on the broad list, but understand you're probably going to collect probably data that's not strictly primary care, and we kind of have to accept that. Or again, because you're not going to get to identifying whether or not they're on part of a primary care team. It's just, in some cases you will, but not in all, depending on how it's built. So it's messy.
It is messy. Michelle?
I'm done. Sorry.
Oh, yes. Okay. Nancy?
Just to say really quickly, I'm pretty sure that our social workers do bill independently, and certainly our pharmacists bill independently, but they're part of our primary care practice. I like that Michelle opened up the door to maybe one day we won't use claims data.
Yes. Jean Marie?
I just wanted to address other folks had asked, you know, what are other states doing, and confirm the fact that most states, as you might expect, do put the behavioral health providers into the broad section, but also reference back and emphasize the earlier slide that Judy talked about with integrated behavioral health. And so just to put that perspective there, that thinking separately between the physical and the mental, as a few of you have noted, that's not entirely, it's not quite that straightforward, and we're aiming for integration here. But anyway, I'm not a committee member, but I'm just referencing back to the statute there.
Great, thanks, Jean Marie. Katina?
I guess my question is, how does our next step that we're going to talk about, the where, how does that intersect with the discussion we're having right now? You know, if the daughter went off to the psychologist that was across town, not associated with my practice, then that where would not be primary care, but maybe they were across the street and we have kind of a deal where we share an EMR. Maybe they are under our roof, but not, maybe they're across the street, but we have that network of kind of what we're talking about in the transformation work. So could you sometimes consider them according to the where?
So, and it could be at your same address, right? If you have a psychologist that you do warm handoffs to down the hall, they could bill separately, but they would be at the same address, and that would be integrated primary care probably, but yes. Tony?
Yeah, it sounds like we're starting to talk about exactly what I was thinking of, and that's for somebody smarter than me when it comes to taxonomy, which is frankly probably everybody on this call. But if those services, social work, pharmacy, can be linked either through a site-based code or a provider code with somebody on the narrow list, it could then be considered primary care. I just don't know the logistics of how that is done, or if it is done, or if it could be done, even if it's not being done now. But I think that's a central part of this discussion, is an ability to expand those primary care services to include all those important team members that are so central to providing the kind of care we're hoping to build up in this project.
Yes, there are some ways to do it. Again, I think it's not exact, but I'm gonna take a stab, because we've sort of talked about almost, actually, maybe let's move to perinatal health, because I think in our conversation, we've probably agreed to keep most of the folks on here. Maybe I'll just take a temperature of that. If there's anyone we'd want to remove or do something different with. Carrie?
I just had a question about terminology. Is the term, a better term, not primary care, but whole person care? You're defining whole person care and who the lead is for whole person care?
That is probably in our definition, and I think primary care is in the statute, so that is what we are sticking with. But we do have whole person care in our definition. So I think the maybe last piece of things to talk about here are about perinatal health and associated providers.
Hey, Judy.
Yes.
I wonder, just what I get, hopefully this doesn't complicate things, but I was just looking at all of the behavioral mental health providers on the list, and I wonder, is there a way just to think about them as is what they provide appropriate to be provided in a primary care setting? And and then I could say yes to almost all of them on the list, but I don't. Rehab seems specialty to me, psychologist rehab. And I wonder if that's a way to look at it. Mental retardation, developmental, maybe specialty. So there may be a few on here. I would say that's I wouldn't expect that to be provided in a primary care setting. And I wonder if there's a couple. So there's a couple for me that if I use that frame of reference, that I would pull out, but all the others I would think could be very appropriately provided in a primary care setting.
Okay, well, let's go back to that slide in a minute after we have this, whether we should add perinatal health and associated providers, which I think is maybe neonatologists, because those are the only folks that would not be captured with the OB, midwife, pediatrician part. Do people have thoughts about neonatologists and perinatal health and whether we should add that or not to the broad list?
I think it opens a big can of worms to add them to the list. There are some, I can see there's post-NICU care that's provided to NICU graduates sometimes by neonatologists. So, and that definitely, I think I would put into the primary care bucket, but I think that's a very small subset of what neonatology really does personally. And I definitely would put them in the specialty category and leave them there personally.
Okay, DC?
This is DC. Actually, I think Cheryl pretty much addressed my question. I wasn't clear on whether neonatologists sometimes do the sort of things that Cheryl just mentioned. It sounds like they do but it's to quite a small extent. And their services would be in a hospital, right? So wouldn't they fail on a site of service, or do they, Cheryl, like have office practices to do that sort of work?
Yeah, the big health systems have them in ambulatory, billing out of an ambulatory clinic, though it probably is. I suspect most of them are hospital based. I know Kaiser has a clinic, Swedish has a clinic. We do a little bit of it at UW, not a lot, DC, for some niche populations. But again, it is a minority of, primarily neonatologists are providing ICU level care in a neonatal intensive care unit or a step down version of that in a hospital setting. I think it gets really complicated to think about putting neonatologists in, especially they represent a big spend. And I think that that would skew the data to include neonatology.
Okay, thank you.
Katina?
I agree with what Cheryl just said. I don't see how that adds to the accountable continuous primary care and adds a lot of money.
Okay. Jean Marie?
Jenny, I think this came from you. Did you want to add anything that hasn't been stated or?
Nothing to add. Nope.
Okay.
Okay, so it seems like there's not, I haven't heard any pros to add them. So I think we'll leave neonatologists out. So Jean Marie, if you could move to the broad list. Yes. And so are there folks to take off of this list to Cheryl's point before finalizing this broad list? And again, noting it doesn't include advanced practice nurses and PAs yet. So Katina, are you ready to talk?
No, I just didn't lower my hand.
Okay.
You're not alone. I suffer from dealing with that too, so you're good. The only thing I would say for folks, if you're thinking about it still too, is that this slide somewhat abbreviates. So obviously where it says et cetera there, I didn't add everything under the sun that's on the Excel spreadsheet for spatial. So for psychologists, I think some of one of you called out the rehabilitation, and there are a few others. So not everything on this screen is captured, but it's giving you the highlights of the different subcategories. So just noting that when you're making your decision.
Yeah, I think. All right, I would say personally, I would remove psychologist, rehab, psychologist, mental retardation, developmental. Let me go on up the list. Adult developmental, and it has aging in it. So I mean, this is again, I had no idea all these different taxonomies existed. So and then for family medicine, maybe it'd be interesting to hear from our family medicine colleagues on the call. So for addiction medicine, bariatric, hospice, palliative care, sleep medicine, sports medicine, should that all, I guess I just don't understand, is that a family med doc who went and got additional training and they are now completely acting and billing as a specialist? And is that the bucket they should be in? Or are they continuing a general family practice and they just have, and they have an interest in these other fields and they're doing a little bit of that while they're maintaining their general family practice? Because if I wouldn't put a pulmonary doc, who's doing sleep medicine, I wouldn't put on this list, but family medicine, sleep medicine's here. So maybe you guys have some insight into that.
Charlie, I think it's a yes, and both of those things happen. There are many family docs that do addiction medicine as part of their practice. They are board certified in addiction medicine. And that's a portion of their practice. There are also some family docs, I'm thinking locally, there's a family doc that's a sports medicine physician. He works in an orthopedic office. He does not do anything primary care. He does sports injury and only sports medicine. So I think there are some of both. I'm not sure that there's a huge spend associated with including them. I don't know, Jonathan, you might have a better idea of what the kind of percentage might be of folks who are doing mostly the specialty medicine and less of the actual family medicine.
You said it far better than I ever could have. And I really don't have much to add. I think the one question, Cheryl, that you may have also had was if there was like dedicated fellowship training associated with this. And for these subspecialties, there are dedicated fellowships, much like there would be in other subspecialties. But yeah, I've seen it both ways. People who just practice that niche, and then people who have this niche as part of their overall broad practice in family medicine. And I can't say I've seen a strong pull one way or another.
And I would say that happens for the internal medicine bit of these two, that it can be both ways. And so I think where this will come out is looking at the where and what of which kind of folks they are, because I know both family medicine and internal medicine docs that are double boarded in addiction medicine, and they use that to provide primary care.
Yeah, I guess it's a slippery slope, because I think, sports medicine, sleep medicine, palliative care, not bariatric, and addiction medicine, those are all specialties in peds too. And we didn't include all of that. So how's that any different?
I would wonder if family medicine, the practice might be different, that if they have those specialties in peds, maybe more of the ped specialists are dedicating more fully their time to the specialty compared to family medicine, who might be spending more time doing general family medicine and a small portion of their time doing the specialty, although there are definitely some that do only the specialty. And I'm not sure if we have that information exactly.
And I'm just going to call on folks because Judy had to switch to phone. Thanks, Katina. DC, you had a question or comment?
Yeah, two comments. So first, actually, Judy said what I was going to say, that the same discussion mostly applies to internal medicine as well. It's my impression that most internists that get double boarded, for example, in addiction medicine, continue to do primary care. And they either do primary care in places with high prevalence of addiction, so it is a major help for them, or they serve as kind of informal or even formal consultants for their colleagues in a primary care group. So that's how I would see it. And I think the same would be true for obesity as well on internal medicine. I think it'd be the unusual internist who would limit their practice to just obesity. I suspect it happens, but I think it'd be pretty unusual.
And how about for the others, DC? Would you continue to include all five then? Or do you feel like addiction medicine and bariatric medicine are more often the situation you explained, and the other three are more likely specialty?
And but Cheryl, by all five, do you mean hospice and palliative care, and then
sleep and sports medicine?
Yeah, I believe that those are probably separate, different from the first two. Yes, I would not include all five as primary care.
Can I just play devil's advocate a little bit? I mean, I think the setting is way more important than what people are double boarded in. And so if I happen to be boarded in addiction and I am in a primary care practice. But I could certainly see someone in, perhaps, and are we looking for the average just for counting purposes, or do we want to cast a wide net? So if I trained in sleep, for example, are we leaving that out of internal medicine? And yet I stay in the primary care practice, I still get counted. I guess I'm trying to figure out what the purpose is. If we want to catch a wide net and we're being attentive to the setting, I think the setting's the more important piece than the specialty.
I would tend to agree with that. I think what I was trying to get at is that the internal medicine practitioners that I know of that do sports medicine or sleep medicine, they're more likely limit their practice to that than I see in the addiction and obesity realms. But
Yeah, I
think
would agree with that. And if there was one that happened to not do that, do we want to count them or do we want to just let them sort of go with the, I guess I'm asking about the purpose of how it's going to impact our counting of on the list.
Yeah, I guess if the majority of you, or even if the data already shows us this, that adding facility on takes care of my question, are they really providing primary care? Are they providing specialty care? If the last leg of the stool here, the facility generally takes care of that, I could be okay. I personally would be okay keeping them on the list if we know that probably, and I forget who said, and does it really matter because it maybe doesn't represent very much of spend anyway. I think that's important. So
this is Mandy. So that's actually a concern. So when we've done the measurement piece of this before with primary care, the place of setting is not clear on the claims. So that's why we go by the taxonomy codes of the providers and then the also procedures. So I don't think we don't really have the setting or the place of service in any way that's good for measurement. So that is kind of a problem.
So Mandy, when the UW folks did our claims, they felt pretty good about the place of service. And I know some others don't. So so I'd like to leave the setting for later in terms of how we can do that. We're definitely not going to get to it this meeting. I also think that some of those things with those different providers can be sorted out by the claims. And we have a laundry list of claims, but you know, for example, if you don't include sleep study as something a primary care person does, then that will kick out if there are some of those. So I think it's both what kinds of things are being billed and what the place of service to sort out some of these.
I just have one thing to add. It's also my understanding that when that a primary, like a family physician is doing the work of a sleep physician, they would add that taxonomy code to the claim. So in that situation with that individual patient, they would be doing sleep medicine and not family medicine, which is primary care. But the next visit, they could be seeing a patient doing primary care and doing general family medicine, and they would add that particular taxonomy, family medicine only, to that claim.
Any other comments, remarks following up on that, or conversation as a whole? I'm looking for hands.
I guess I'm thinking and sort of putting this all together. I think there are no changes based on what we've talked about to this broad list. Do people have anything else to add in that, or shall we make a motion?
This is Crystal. I did notice there were a few things missing from the list, like allopathic that I thought, and like a general practice taxonomy code. And I can send those specifics. I apologize, I didn't before.
And Linda, you have a comment when Sharon.
Yeah, I just have a question. So on this broad list, and I know there's a separate slide associated with advanced practice nurses and PAs, but here we've got the advanced practice midwife and the midwife on this particular list. And I'm not 100% clear how that developed. I know we're going to address the other slide, I think, because a lot of the providers on that separate slide for advanced practice, which again has the different taxonomies, would be considered really probably on the narrow list, and but yet they're separate. So so with advanced practice nurse practitioners, say ARNPs in Washington State, there are 4 roles. So it's not advanced practice midwife, it's CNM, certified nurse midwife. Then there's the nurse anesthetists, nurse practitioners, and clinical nurse specialists. So I wasn't sure because the terminology isn't actually accurate. But I also didn't understand why it was on this broad list. And I don't think it matters per se. They can be included on lots of lists.
Yeah, I apologize that is confusing, and I agree when we get to the next slide, which I think might be the next meeting. Maybe one thing we'll do is to sort some of those into what goes into the narrow list and what goes into the broad list, because I think there's both there. And that's an excellent point.
Great, thanks.
And Sharon, you wanted to make a comment or ask a question?
I just was wondering about the social worker at school, but then noticing, knowing that it is on our list with the taxonomy makes it seem like you could find, a claim or something for that. So there's like a school social worker, that's even, like outside of the context of a primary care practice, but we can probably just ignore that question.
It does have its own taxonomy code, if that's what you're getting at, separate from,
Yeah,
I see it.
But I think it maybe could, that kind of person could go practice somewhere else besides school.
Okay, I see.
And it could be a school-based clinic.
Yes.
So it could be a pediatrics clinic in the school that has the social worker, and they are doing true primary care, integrated behavioral health together.
Okay, got it.
Any other comments that I may be missing while I'm scanning?
Or can we have a motion? I'll prod a little.
Do we want to have a motion to accept the broad providers that we currently have? And then if we want to tackle at the next meeting, if there are people missing, because I know Crystal and others have mentioned that we could expand upon the list, but at least accepting the folks that are here. Is that the motion you want to make, Judy?
I don't think I can make that motion, but I would love that motion to be made.
I'll make a motion to accept the list as it is.
Second.
All who agree say aye.
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 And those who disagree? Great.
Okay.
So we're making progress. I think I want to just tee up where we'll start for the next meeting. And again, I did expect that this would take a while, and I think we're getting a little better as we get our brains around this and start thinking about some of these questions. So I'm not at all surprised that I think as we work through these things and start to have these conversations, it's really going to help us for the things to come. So next time, which is next month, we will start with the advanced practice nurses and the physician assistants, and we'll slot those into a proposed narrow and broad category to start the discussion. And then we'll do the facilities, and we will plan on sending out the start of the procedure list, especially for people to respond to, because I think it's helpful if you guys have time to really think about the codes in between. I am not certain we will get to that in the next meeting, but we might start, and I think seeing that list might help your thinking as we move on that. So any questions or comments about that?
I'm not seeing anything, Judy, and no one's piping.
Perfect. And so then the other thing just to note, this process is a little iterative, and besides, you guys are a subcommittee of the cost board, and there are other subcommittees, and there's the cost board itself. And so in between this meeting and our next meeting, there will be a couple of presentations to other groups about where we are. And then we will continue this conversation February 23rd. And I am happy to have comments or questions or other things in the interim that we can bring up again. And thank you for your time.
All right. Thanks, everyone.
Great. Thanks, everybody. Have a good day.
Thanks.
Thank
Bye.
you.